Thanks for being with us today and enjoying the great content put together by Trio Maryland. Don't forget to join us at 12 p.m. Eastern Standard Time for the day's wrap-up and t-shirt raffle. We want to continue to recognize our event sponsors. So now for a word from the National Kidney Foundation and Peak Relief.
I was diagnosed with rejection in March of this year, so the pandemic was extra terrifying for me. While everyone was out buying all the hand sanitizer and toilet paper, I was being released from the hospital with no immune system.
My wife Michelle had a diagnosis of kidney disease. She had a massive cardiac event due to complications from COVID, and I can safely say, as a kidney patient, my wife died from COVID-19.
I lost my mom, a kidney patient, from COVID. Then I remember the last time seeing my mom alive, taking her last breath through a glass window, to not be able to touch her while she still had breath in her body. Mental agony.
We were thrown a curveball when I was diagnosed with a rare kidney disease. That scared me. It still does.
The National Kidney Foundation is doing so much to protect patients during this pandemic, to make sure that what happened to my wife Michelle doesn't happen to them.
With the Kidney Foundation's help, we've been able to overcome some of our fears and live healthier, happier lives.
The National Kidney Foundation does so much, so much.
A few housekeeping items before we begin. Recording. This webinar is being recorded. Recordings will be sent to all participants after the event. General meeting room. Chat face-to-face with other participants. This Zoom room will be open from 10 a.m. to 12 p.m. Eastern Standard Time. Link will be available in the chat box at the end of the session. Support. If you need support, please text 410-635-8255 0229. Comments and questions. Please use the Q&A feature to ask questions, which will be answered by the presenter at the end of the session. Chat box. Please use the chat feature to communicate with other participants. This is a webinar format, and you will not be able to see or hear other participants. Our last session of the day is solid organ transplant recipients and COVID-19, a brief update. Please remember, you can post your questions in the Q&A tab, and we will share with the speaker after the presentation as time allows. We're excited to have Dr. Seema Mehta Sainki, an infectious diseases physician. Prior to moving to Colorado along with her military husband, she held a joint appointment as assistant professor in the School of Medicine and in the School of Nursing at Johns Hopkins University for 6 years. Her clinical focus while at Johns Hopkins was transplant and oncology infectious diseases, providing infectious diseases care for oncology patients, as well as solid organ and bone marrow transplant recipients. Welcome, Dr. Seema Mehta Sainki. Please take the floor.
Hi, thank you, everyone. Let me just share my screen here. All right, so my talk today is on solid organ transplant recipients and the COVID-19 and a brief update. So today's talk is going to talk about the COVID-19 vaccine and where we stand today. We're going to talk about emerging strains of COVID-19, and we're going to talk about guidance on protective measures to take. The objectives for today's talk are to describe the COVID-19 vaccine landscape at present, summarize the data on COVID-19 vaccine response and safety in SOT recipients, and review COVID-19 emerging strains. We'll also discuss vaccine efficacy against emerging strains and explain guidance on protective measures. So the US COVID-19 vaccine landscape as of May of 2021, currently there are 3 vaccines available, the 2 mRNA vaccines that we are all familiar with, including the Pfizer-BioNTech and the Moderna. And then there is a recombinant replication incompetent adenovirus type 26 vector vaccine, which is the Johnson & Johnson vaccine or the Janssen vaccine. None of these vaccines are live vaccines. The authorized age groups to receive these vaccines are currently 16 years and older. Specifically, Pfizer is for 16 years and older, whereas Moderna and the Janssen vaccine are for 18 years and older. And hopefully within the near future, we will have FDA approval for the Pfizer vaccine to be given to the age group of 12 to 15 years of age. So this is just a brief review of the number of doses and the interval between doses for each vaccine. So the Pfizer vaccine is 2 doses given 21 days apart. Moderna is 2 doses given 28 days apart, and the Janssen vaccine is just 1 dose. So specifically talking about the interval between these doses when you have to receive 2 doses, the second dose should be administered as close to the recommended interval as possible, but ideally not earlier than recommended. However, there is a grace period of 4 days earlier than the recommended date for the second dose, and that is still considered valid if you receive it within that 4-day grace period. The mRNA vaccines are not interchangeable, so we do not have any safety or efficacy data on mixing the products. So if you get the Pfizer to start out with, you should complete it with the Pfizer and similar to the Moderna. The second dose may be administered up to 6 weeks after the first dose if a delay for whatever reason becomes unavoidable. So what happens if you get COVID-19 before or during your vaccine series? So if you had prior symptomatic or asymptomatic COVID infection, should you get the vaccine? So your immunity wanes with time, but how much time? We don't really know. Immunity is good in the initial months following infection, but after that, we've seen that it can wane, and this places you at risk for reinfection. So the short answer to this question is yes, you should still get the vaccine. What if you currently have COVID-19 infection? then you should defer vaccine until you have recovered from your illness if you are symptomatic, or until you have met criteria for discontinuation of isolation if you were asymptomatic. So if you're symptomatic, for immunocompromised patients, such as solid organ transplant recipients, that is generally 20 days after you no longer have symptoms. So a minimum of 20 days. Sometimes you can do 10, but you need to be tested for clearance of the vaccine first, or sorry, of the virus first. And you should wait at least 24 hours after having a fever without receiving any fever reducing medicines such as Tylenol. And you should ensure that all your other symptoms are improving. If you are asymptomatic, then you simply need to wait 10 days after your positive test result before you can discontinue your isolation. So similarly, those who receive antibody therapy, such as convalescent plasma or monoclonal antibody therapy, should defer vaccination for a minimum of 90 days after receiving this antibody therapy. And this holds true even if you get COVID-19 infection in between your doses of vaccines as well. So if you get the first dose of Pfizer, come down with COVID-19 and get convalescent plasma, for example, you should wait 90 days after having received the convalescent plasma before you proceed with your second dose of the vaccine. So what about administering the COVID-19 vaccine with other non-COVID vaccines? So just to reiterate, none of the currently authorized COVID-19 vaccines are live vaccines. But that being said, there is no data on the safety and efficacy of COVID-19 vaccines administered simultaneously with other vaccines. Therefore, they should be administered alone and with a minimum of 14 days before or after administration of any other vaccine. So they do need to be spaced out. So if you are a pre-transplant candidate and they are bringing you up to speed on different vaccines, you should not receive the COVID-19 vaccine while you're receiving the other vaccines. You should wait a minimum of 14 days either before or after receiving the other vaccines to proceed with the COVID vaccine. And what about booster doses? So the need for and timing of COVID-19 booster doses has not been established as of yet. And at this time, no additional doses are actually recommended. So let's delve a little bit into the Janssen COVID-19 vaccine and some considerations that we need to take here. So on April 13th, 2021, the CDC and the FDA recommended a pause in the use of the Janssen vaccine after reports of US cases, after reports of US cases of thrombosis with thrombocytopenia syndrome, or TTS, among the COVID-19 vaccine recipients who received the Janssen vaccine. So what is TTS, or thrombosis with thrombocytopenia syndrome? It is a rare syndrome that involves acute blood clots and new onset low platelet count. So on April 23rd, 2021, so 10 days later, the Advisory Committee on Immunization Practices, which is a subset of the CDC that manages all immunizations and determines the schedule with which we receive immunizations, they put out a statement essentially reaffirming the use of the Janssen COVID-19 vaccine in all persons ages 18 and older. So they basically said, despite this risk, we can still go ahead and proceed with giving this vaccine. But the caveat was that any woman ages 18 to 49 can receive any FDA authorized COVID-19 vaccine, but they need to be aware of the rare risk of TTS development after receipt of the Janssen vaccine. And it is specific to women 18 to 49. The TTS reporting rate, there have been 7 cases per million doses administered to women ages 18 to 49 years, and 0.9 cases per million doses administered to women ages 50 years or greater. So the highest risk group is that 18 to 49 age group, which is why the ACIP has reaffirmed that you can use this, but with the caveat that you must inform these women of their risk for developing TTS. So what about the vaccine and autoimmune conditions? So people with autoimmune conditions such as lupus, scleroderma, rheumatoid arthritis, things of that nature, were eligible for enrollment in the COVID-19 vaccine trials. And those patients that were with autoimmune conditions and in the trials, they evaluated them, and there were no imbalances observed in the occurrence of symptoms consistent with an autoimmune condition or inflammatory disorder in people who received the vaccine as compared to people who received placebo. So, in other words, there was no flare of anyone who had an autoimmune condition that received the vaccine. So they were able to receive the vaccine and proceed without receiving or without having a flare of their underlying autoimmune condition. And people with autoimmune conditions at this point may receive any FDA authorized COVID-19 vaccine. But we need to keep in mind, and this, I'll go into some of this a little bit more in the talk later on, those receiving mycophenolate and or rituximab may have a blunted immune response to the vaccine. So let's talk about the vaccine and SOT recipients. I'm going to go through a series of studies here. The first study I'm going to talk about is a Hopkins study that was published in March of 2021. This recruited 436 solid organ transplant recipients who underwent their first dose of an mRNA vaccine between 12/16/2020 and 2/5/2021. They assessed the proportion of patients who developed a positive antibody response 20 days after receiving the first dose. 52% received the Pfizer BioNTech vaccine, 48% received Moderna, and you can see here that the majority of the patients were kidney transplant recipients, at being 41%, and you can see the remaining breakdown here. The antibody response was detected in 76 of 436 participants, so that places it only at 17%. Mind you, this is only after receiving the first dose of the vaccine. They noted only 17% of the participants had an antibody response. Those receiving mycophenolate or anti-metabolite therapy, such as azathioprine, were less likely to develop an antibody response. Older transplant recipients were also less likely to develop an antibody response. And by older, from this slide forward, is generally referring to patients 60 years and older. Though I do not believe that to be necessarily an old population, that is what they categorized older transplant recipients in these studies going forward. And those who received the Moderna vaccine were also more likely to develop an antibody response than those receiving the Pfizer vaccine. So let's move on to the next study, which was a European study published in April of 2021. This evaluated 24 solid organ transplant recipients, 14 heart recipients, and 10 kidney recipients. All of these people received the Pfizer vaccine. The antibodies were measured 10 days after the second vaccine dose, and antibodies were detected in 20 of the 34 recipients, so 58.8%. Anti-metabolite, or as I said, mycophenolate, or mycophenolate is also called Cellcept or Myfortic, or a medicine called azathioprine. Anybody on those meds was the only factor that they saw negatively impacting an antibody response. So ultimately, they concluded that there is essentially a reduced antibody response to the Pfizer BioNTech mRNA vaccine. So let's move on to the next study, which was an Israeli study of liver transplant recipients, and this was published also in April of 2021. They evaluated the antibody response in liver transplant recipients. Antibody levels were tested 10 to 20 days after receiving the second dose of the Pfizer vaccine. They looked at 80 liver transplant recipients, and only 47.5% developed an antibody response. That was 38 people. So those who developed an antibody response, actually, they demonstrated that they had antibody levels that were 2 times less compared to the healthy participants in their study. So what were predictors of lower antibody response? Again, older age or age greater than 60, decreased kidney function, and treatment with high-dose steroids as well as mycophenolate, Cellcept or Myfortic. So let's move on to another Israeli study, this one looking specifically at kidney transplant recipients, also published in April of 2021. There was 136 kidney transplant recipients. 51 of the 136 transplant recipients had an antibody response. This was only 37.5% of the participants. Antibody levels were higher in those who did not have a solid organ transplant. So there was a reduced antibody response that they saw associated with, again, older age, high dose of steroids in the prior 12 months, receiving what we call maintenance triple immunosuppression, which essentially includes Prograf or tacrolimus, mycophenolate, which is Cellceptor Myfortic, as well as steroids such as prednisone. Or they said any immune suppression regimen that included mycophenolate caused a reduced antibody response. So this slide, I had to submit my slides before the publication of this data. So unfortunately, I don't have all the numbers in this slide, but this ultimately ended up being published on 5/5/21. And this was another Johns Hopkins study where they extended their initial study to include the 2 vaccine doses. This time, their total population of patients they looked at was much larger, with several thousands of solid organ transplant recipients. Their vaccine response was better, but still not great, with only 54% of the total population they looked at having an antibody response to both vaccine doses. In their study, mycophenolate remained a factor contributing to poor antibody response, as well as older age. But they did note that the further out from transplant you are, so 6, 10, 15 years, et cetera, the more likely you were to have a better immune response. And they also showed, again, that Moderna has proven to produce a better antibody response than the Pfizer vaccine. And out of a large number of patients, they are seeing a fair number of breakthrough infections despite full vaccination. And when I say full vaccination, that means having received both doses of the vaccine if you received the Pfizer or the Moderna vaccine. So some take-home points regarding the vaccine and solid organ transplant recipients. So SOT recipients remain at high risk for COVID-19 despite vaccination. SOT recipients who are older are at increased risk of having a poorer antibody response. And recipients who are receiving mycophenolate are also at increased risk of having a poor antibody response. So I can't stress enough, but SOT recipients must continue to abide by the prior CDC guidance to decrease your chances of acquiring or being exposed to COVID-19. What are some additional take-home points? The big thing is, don't panic after hearing this information. There will be interventions in the future to improve the antibody response. This may include looking at additional booster doses, which studies are actually ongoing evaluating the need for this. And also studies are ongoing comparing the different vaccines to determine if one is specifically better than others for solid organ transplant recipients. The bottom line is your antibody response does improve with the second dose, but we need to find a way to make it better. And I will say briefly that when we studied the flu vaccine when it was first coming out in solid organ transplant recipients, we also saw lower antibody levels develop. But despite the lower antibody levels, it was still effective. There was still a decrease in flu-related lower respiratory tract infections in solid organ transplant recipients, despite the lower antibody response. So even though we need to make things better with this vaccine, if you have an antibody response, that is better than nothing. So it is helpful, but you still have to continue to abide by the prior CDC guidance to decrease your chances of acquiring or being exposed to COVID-19. And lastly, if you do develop COVID-19 symptoms, whether or not you've been vaccinated, you must contact your transplant coordinator early. And I can't stress early enough. There are studies that are going on right now that show that monoclonal antibody therapies, such as Regeneron or the Lilly drug, also abbreviated BAM, appears to be potentially quite effective in solid organ transplant recipients, but only if that drug is administered very early on in the illness course. So it's imperative that you should contact your transplant team very early on if you develop COVID-19 symptoms or find out that you have a COVID positive test. So let's look at briefly the safety of the vaccine in solid organ transplant recipients. So safety data published on the COVID-19 vaccine in solid organ transplant recipients actually reveals that it's very safe. There have been no episodes of rejection, no neurologic side effects, and the side effect profile appears to parallel that of the general population. So, in other words, we're not seeing worse adverse events or side effects as a consequence of giving the vaccine to solid organ transplant recipients. So, if you can get it, you should get it. So let's move on briefly to discuss emerging strains of COVID-19. There are variants of the COVID-19 virus that have several mutations specifically on the spike proteins. The spike proteins, and you can see here in this slide, are these little pink projections off this virus on this picture. The spike proteins are used by the virus to attach to and infect human cells. The spike proteins are also what vaccines and antibody drugs are targeting. So viruses are constantly evolving through mutation, and new variants are expected to occur over time, regardless of the type of virus that you're talking about. So many of the variants of COVID-19 virus are circulating globally and within the US. Potential consequences of such emerging variants include the ability to spread more quickly from person to person, the ability to cause either milder or more severe disease, the ability to evade detection by specific viral diagnostic tests, decreased susceptibility to therapeutic agents such as monoclonal antibodies, and the ability to evade natural or vaccine-induced immunity. So there are classifications. The CDC has classified or created 3 classifications for these variants that are being monitored. The first classification is variant of interest. A variant with specific genetic markers that have been associated with possible reduced susceptibility to antibodies and treatments, as well as a potential increase in transmissibility or disease severity. So this is all, they're speculating that it has these characteristics, but they haven't proven it yet. At this point in time, there are 3 strains like this present in the US. The variant of concern is a little bit more established in that there's evidence that there is increase in transmissibility, more severe disease, and significantly reduced susceptibility to antibodies and treatments, or reduced ability to detect it on the diagnostic tests that we have available. At present, there are 5 strains in the US that are considered variants of concern. And then there are variants of high consequence. So this has clear evidence that prevention measures or medical countermeasures have significantly reduced effectiveness. And thankfully, there are currently no variants of high concern at present in the US. So let's briefly talk about the variants of concern that are present. So the first one is the UK strain, which was first seen in the US in December of 2020. There's a 50% increased transmission rate, so it's more contagious, also likely with increased severity of illness, but we are seeing that the vaccines are still effective against this for the most part. Then the next strain is the South African strain, which was first seen in January of 2021 in the US. This also has a 50% increased transmission rate, so more contagious. And what we're seeing is that the vaccines are actually less effective against this strain. Then we have the Brazil strain, which was also seen in January of 2021. The vaccine efficacy against this strain is unknown, as are other parameters. They are still investigating this strain more closely, but they are concerned and therefore have classified it as a variant of concern. And the last 2 strains are both called the California strains. They're slightly small variations between the 2 viruses, but they're both considered California strains, first identified in the US on February of 2021. This has a 20% increased transmission, and we are seeing that vaccines are likely still effective. So there have been some studies published since the rollout of the vaccine, which one study here shows 417 persons who received the second dose of the Pfizer or the Moderna vaccine. So they were fully vaccinated. And out of that 417, they identified 2 women, so only 0.5%, with vaccine breakthrough infections at least 2 weeks after receiving the second dose. One was 19 days and the other was 36 days. After testing these women, the authors were able to conclude that both patients had effective immune responses to the vaccines. The immune responses they mounted were simply not as sufficient to prevent infection with the variant strains identified in these 2 patients. And these 2 strains were not any of the variants of concern, but they were closely related to some of the variants of concern, specifically the UK strains. Again, another study. This was a study conducted from December 16th to February 9th, looking at nearly 15,000 healthcare workers at UCLA and UCSD, which had been fully vaccinated, so received both doses of the vaccine. Out of that near 15,000, only 7 people, so 0.05%, tested positive 15 days or more after the second dose of the vaccine. They deemed their vaccine recipients to be, quote, younger and healthier, but they did not elaborate upon that statement, than what was captured in the vaccine trials. So the take-home point of these 2 slides is, although it's happening at a low rate, it's still happening. So we need to take precautions, given that we've talked about the fact that there are lower antibody responses in the solid organ transplant patient population. Some data will be forthcoming in the future indicating that there are some breakthrough infections despite vaccination in solid organ transplant recipients. And so because of all that, we need to still take all precautions necessary to prevent exposure and acquisition of the infection. So again, what does this all mean for solid organ transplant candidates and recipients? The lack of the immune response in solid organ transplant recipients, along with the emergence of strains that are breaking through vaccination, places SOT recipients at continued risk for COVID-19 exposure and acquisition. It is still very important to get vaccinated because, as I said earlier, some immunity is better than no immunity, as we see with the flu vaccine. We are still just studying this further to understand what this lower antibody response translates to and how it plays out in reality. So suppose you've already been fully vaccinated. Now what do you do? The CDC has recently put out their guidance on what the general population can do, but I don't think that necessarily can apply to solid organ transplant recipients based on what we're seeing in the literature and what I've presented today. So if you are an SOT candidate or recipient, you should continue to take all precautions previously outlined by the CDC. So that includes wearing a mask, and most recently they recommended 2 masks, 1 surgical mask covered by a cloth mask. You should continue to stay 6 feet away from others, avoid crowds and poorly ventilated spaces, wash your hands often, cover your coughs and sneezes, clean and disinfect, and monitor your health daily. So it's imperative that all these precautionary measures continue to be taken. We don't yet know enough to say it's safe to remove these precautions for solid organ transplant candidates and recipients, but we know enough that we need to continue to take these precautionary measures because we know that we still don't know enough, if that makes sense. So this concludes my talk. These were some of my references. Additional references were embedded in the slides. And thank you. Please contact me if there's any questions or concerns.
Thank you so much, Dr. Steinke. We do have a couple questions in the Q&A, so I'll begin.
Sure.
Question 1. Kathy said she's a fully vaccinated liver and kidney recipient. What do you recommend as far as interaction with unvaccinated grandchildren and going to indoor restaurants?
So I would recommend that you continue to take the necessary precautions that you would have taken if you weren't vaccinated to be around unvaccinated grandchildren or children. And I would still recommend avoiding indoor restaurant dining. It is actually considered one of the highest risk activities that one can participate in, even if you are fully vaccinated and completely healthy without having any immune compromising situation. So I would say I would avoid indoor dining and continue to take the precautions you were taking prior to the vaccine having come out with regards to interacting with unvaccinated people.
Thank you. Second question is, are COVID vaccine supplements going to be recommended for immune suppressed individuals?
So by supplements, I think that means a booster dose. So that we do not know. That is still an ongoing study. I know for a fact that those studies are underway. It's just too early to have any kind of preliminary information from those studies that are ongoing at this point in time. So I don't know, but stay tuned as we will get more data in the near future.
Our next question, are there any antibody tests given at JHH or elsewhere for transplant patients who have received full Pfizer doses to ascertain their status?
Yes, you should be able to go to any physician and request for an antibody test, and they will be able to order it for you. There's no reason to not get the test if you've been vaccinated and want to know your antibody status.
Wonderful. We have one more question here.
Sure.
The attendee is asking, I'm a patient at the Hopkins Comprehensive Transplant Center, CTC. I've had 2 doses of the Pfizer vaccine. I had fever and body aches after the second dose. How can I determine if I'm protected? Can Hopkins CTC measure my antibody response?
Yes. So I would contact your transplant team and talk to them. And your transplant coordinator should be able to communicate with either the infectious disease specialist at Hopkins or your transplant physician themselves to determine if it is appropriate. But generally speaking, there should be no reason not to be able to get that test. So it should be acceptable to go ahead and contact them and see if you have produced enough of an antibody response.
Next question. Pfizer and Moderna vaccines advertise 93% efficiency rate. What is the efficiency rate for those who are transplanted?
So at this point in time, it's looking to be around 50 to 60%. Based on the studies that I presented. The one study was 58.8. The Hopkins study that just came out this week on the 5th of May was 54%. So it's looking to just be in that ballpark.
Next question. I'm on blood thinners. How will these vaccines affect me?
So there is no interaction with blood thinners at this point in time that we're aware of. So there should be no reason to worry about any kind of interaction with them.
Next question. When will the second shot data be available from the Hopkins study?
So I believe I presented that. That was the one published on May 5th, the one where I said I had to submit my slides a little sooner than I was able to get the data. But I included 54% in there as that being the effectiveness rate in that patient population after the second dose.
And the next question is, define what a blended response is in terms of percentage effectiveness in solid organ transplant recipients.
So again, that's about 50 to 60%. So we're not seeing antibody responses higher than 60% in the solid organ transplant population based on the studies that have all been published, which I presented all of them today.
The next question is, how can we access the full Hopkins study that was just published?
So you should be able to Google it. It was published in JAMA. If you just look up JAMA solid organ transplant COVID-19 vaccine, you will see a series of studies, but it was just published this week. So you should be able to see it pretty readily online. And they've made all those articles free to public access, so you don't need to have a subscription to be able to access it.
Next question. When you say follow the prior CDC guidance, what specific steps are you referring to?
So I think I summarized that in one of my last slides, but basically it's wearing the mask or 2 masks, staying 6 feet apart, avoiding crowds or poorly ventilated spaces, washing your hands or hand sanitizing very frequently throughout the day, covering your cough and sneeze, monitoring your health to make sure you don't develop any symptoms that are concerning. So that's pretty much it. The CDC keeps revising their data based on the general population, not based on the immunocompromised population. So until we have more data and until your transplant coordinators or team tell you that it's safe, I would continue taking all the precautions that we've just discussed that were previously outlined by the CDC prior to the vaccine rollout.
Next question. Have the studies indicated getting the vaccine doses have reduced the hospitalizations of SOT recipients compared with prior to the vaccination available? Are we less likely to be hospitalized after receiving vaccine doses?
So that they do not have data on that yet. That was not any of the outcomes looked at from any of these studies, unfortunately. So they are still in the process of looking at that. And I assume that will be part of the studies that are released when they discuss the breakthrough infections with the vaccine recipients. So until we have that data, I am unable to say what the hospitalization rates are looking like.
Okay, Dr. Psyche, I think we have time for about 2 or 3 more questions.
Sure.
Next question. What advice do you have for fully vaccinated SOT recipients for whom antibody testing shows a robust antibody response? Still the same precautions?
So I would still take precautions. I think if you have a robust antibody response, you may be in that category of the 50 to 60% who had a good antibody response. But as one of the studies I presented indicated that there was the antibody levels compared to healthy people, even if you had a response, was 2 times lower that of the healthy people. So I would still say take the necessary precautions, because until we get more data, I just don't think we can say with certainty that, even if it's considered a robust antibody response, what that means in comparison to people who are vaccinated to 93 to 95%, if that makes sense.
The next question is, what are the chances Novavax vaccine would be approved by FDA before fall 2021? Are there any additional studies being conducted on SOT COVID vaccine efficiency? If so, what are studies results expected?
So that I am not aware of. Actually, I'm not familiar with any studies that are out there or pending or ongoing at this time, looking specifically at that vaccine. And I do not know if we will have it by the fall or not.
We have time for one last question. Do you recommend getting a semi-quantitative COVID-19 antibody test? How reliable are these and how helpful? I know I've done antibodies in JH study, but I do not know what that means. I do take myco, and I might need your help for this.
Sure, mycophenolate.
Thank you. That's her question.
So I think if you've participated in the Hopkins study, then you would have received an antibody test that looked at it fully quantitatively, not semi-quantitatively. That being said, a semi-quantitative test may be helpful, but it may not be fully telling of your vaccine response. Also, since you are on mycophenolate, as I've pointed out, there is the likelihood or the high chances that you had a lower antibody response. I'm not sure. I can try and find out from my colleagues who are doing the actual studies in the COVID vaccine trials for solid organ transplant recipients. I can try and find out if there are specific ways for you to get your test results if you participated in the study. I can certainly let Michelle or Marty know about that once I find out.
Okay, Dr. Psyche, thank you. I just wanted to make a quick programming note. We are about 2 minutes out from the session being closed for today, but I have taken a note of all of the remaining questions in the Q&A. And so I will have Dr. Psyche answer those, and I will provide that to everyone that's participating today. So those questions will not get unanswered. We will have answers for you after the fact. So Dr. Psyche, I will send you the remaining questions, and then we will distribute the answers to all the participants.
Sounds great. Thank you.
Okay, thank you. And thank you, Dr. Psyche, for sharing with us all your insight and expertise. We want to thank Trio Maryland again for the great programming and informative event. This concludes the session for today, but we encourage you to jump immediately to the closing Zoom, and I'm putting the closing session Zoom link in the chat right now. So you should be able to click directly to that Zoom link to attend the last session of the day, which is our closing session. And again, Dr. Steinke will get a message with the remaining questions, and we will share her answers with you in the next week. All right, Dr. Steinke, we appreciate your time, and this concludes today's session. Thank you all, and we hope to meet you at the next session.
Thank you.
Thank you.